a huge honor for me to be in this master class because I feel like I'm in the middle of giants here. Um, let's see, this is the giants that I'm standing right now with. Thank you for the opportunity, and I feel like well, in the time that I was in the same uh, spot with Steve Vai, Ingrid Malmsteen, it feels exactly like this. Thank you. And I will give some simple tips for our colleagues in Indonesia on retrograde intrarenal surgery. And the first tip is something that I always give to our colleagues here. That is semi-rigid ureteroscopy and retrograde intrarenal surgery are two different beasts. You cannot do the RIRS with URS, with semi-rigid URS in your mind because it will definitely broke your equipments. So this is the difference. For URS, the main movement is forward. Mostly we aware of the front view of the surgery, and also we have the main movement with our dominant hand. But in retrograde intrarenal surgery, the main movement is more three-dimensional: rotation, flexion, advancement, retraction. And we must aware of the three-dimensional environment, and the movement is synchronized between our two hands. That's two very different skills, I think. Different position, different mindset. You have to be very careful on that because, again, if you do rears with the URS mindset, you will definitely broke your equipments. And this is the position that I learned from Professor Traxler. Thank you, sir. The position is like a boxer when you stand. And I also recommend to put your elbow beside your body so you don't put too much pressure on your shoulder. And this is the position. So you can do flexible ureteroscopy in a long time without giving pressure to your body. And the second tip, it will be patient. This is a very important tip because you cannot do forcing movement. You cannot force your equipments to the ureter, to the kidney. Well, I perform PCNL also. It is I think it is 180-degree different with PCNL because in PCNL you have to push something to the body, but in retrograde intrarenal surgery, no forcing movement. The ureter is fragile. The flexible ureteroscope is fragile and expensive, so you have to do it very smoothly. I sometimes says you have to do the surgery like you treat your woman. You have to treat very smoothly. Okay, difficult urethral access seat insertion. For me, I advise you to stop. Stop it, put the digistand, and the second look will be easier. 4 weeks later, you do the second look and it will be much easier. The ureter will be dilated. That's very important. The first two tip is something you have to always to consider. And actually, I learned this from from our colleagues' experience. I always put my feet uh, on this position because if you press the laser, you hit the laser while the laser is not in the right position, then you will destroy everything. You can destroy the kidney, you can destroy the ureter, or you can destroy your expensive equipment. So please, this is I think this is the first thing that I recommend to our resident when they try to perform laser surgery. Please put your foot somewhere else, not here when you don't hit the laser. Put it somewhere else. And I prefer to put it here because it will be easier to go down. Okay, this is interesting for a peeping stone. So sometimes it will make you, well, how we can describe it? The stone is there, we can see it, but it is difficult to reach the stone. What shall we do? In my experience, I learned this from Dr. Nurashid, actually. I will put the laser as close as I can to the stone, and then hit the laser. The stone will reach the fiber when you do that. Of course, when the stone is not too big, because um, when you hit the laser will make the water hotter, and it will push the stone. The colder water will push the stone toward the fiber, so it will move the stone. Most of the time, we will be able to disintegrate small stones, small peeping stones this way. I think this is, I also give this tip to the residents when they perform the surgery, the RIRS, and have difficulties reaching the stone. The stone is there. I can see that, but I cannot reach it. And reaching the lower pole stone, sometimes in my early experience, I broke one flexible ureteroscope. Because of this, I broke one of mine. Because I force it. I force it to reach the stone. When it's difficult to move the stone to an easier position, then I will do the passive deflection. Passive deflection will always help. I do the passive deflection actually by putting the flexible ureteroscope in the calyces, and then I push the flexible ureteroscope following the calyces, so it will bend according to the calyces, and then I can shoot the stone in the lower pool easier with this passive deflection. Unlike if you do only the active deflection, it's very difficult to reach the lower pool, especially with this kind of angle. It is difficult. So my tip is you have to learn how to perform this passive deflection because it will be useful. It will be useful many times. And also less pressure in moving parts. But I have to give my experience also. If you use a too small fiber, perhaps the 200 micron fiber, the passive deflection will give pressure to the fiber and it can be broken inside the flexible ureteroscope. So during passive deflection, I prefer a bit bigger fiber. Perhaps I will use the 365 micron fiber, so it is harder. On irrigation, I think this is the last tip, the irrigation. Visualization is one of the most important thing in retrograde intrarenal surgery. Many irrigation devices available, but and we have to do it safely. But in my opinion, the best irrigation device is the manual hand operated syringe, because I performed it with the nurse that also performed RIRS many times. So he can tell me, doctor, I think this is harder. Perhaps there's something in there that you have to consider. And then I will see. And they will give the smallest tension, the smallest pressure, so we don't cause a fornix rupture, like Professor Trexler mentioned before. Like this, but I use any 20 cc syringe will be fine. And this is the general tip. Flexible retroscopy is not one answer for all in kidney stone management. It's expensive, use it wisely, and start from the surface to stone. For kidney stone, of course, it will make bigger fragment if you start from the middle. I like to position the patient head down. The fragment will move to the upper pole, which is easier to manage. I also prefer to do first brushing, and when I encounter difficulties, I will go to drilling. Don't force your equipment. Use it gently, like you do your woman. Use it gently. In difficult case, don't hesitate to stop. I think that's all. Thank you.